Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas. Welcome back to the program. This is Averill Kelly. This week, we are again with Shaver and Graydon Ratushny from British Columbia. Lads, welcome back to the program.
Thanks for having us.
Thanks for having us back, Averill.
So, both of you have already been on guests on our podcast. What have you been doing lately to keep yourselves busy?
Well, we are both active students in the Master's Austere Critical Care Master's program, and Cole and I elected that it would be a good idea that we'd go down and do our clinical rotations in Kibosho. So we had the opportunity to spend just shy of 4 weeks, about 4,500 feet up the side of Kilimanjaro, working with some of the physicians and nurses in remote and rural Tanzania.
That's fantastic. So all the world, you looked to get your experiences in an austere ICU, and you chose Kibosho.
It's been an amazing journey kind of through our healthcare education so far, and I can speak for myself. I've had the opportunity to work in metro centers, rural centers, situated in Western medicine, and the opportunity to go abroad and work in somewhere that doesn't necessarily subscribe to 100% of the practices of Western medicine, that really makes do with what they have and really works around the resources that they have at their hands, as well as just the implications of a different healthcare system, was an opportunity that I couldn't pass up. And I know Cole and I both had an amazing time down there.
So tell us about Kibosho. So we've talked about this before a bit. Did you spend any time at KCMC?
No, we did not.
Did you get a tour at least?
The emergency department on a few transfers, we kind of poked around, but it was very brief.
So Kibosho has an ambulance for transfer.
They do.
And are you doing any 999 type calls? Do you respond? Do people call you?
No, it seems like in the African healthcare system, at least in that area, the ambulance is purely an interfacility conveyance device. There's no way to have it come to your home, at least not that we were aware of. So it's purely for you've shown up at the small rural hospital and you need to be referred out to another facility.
So tell us we'll start with that. So you're doing critical care transport. What kind of cases are you moving from Kibosho down to Kilimanjaro Christian Medical Center?
It's similar to a lot of places in the world. CT scanners are expensive and few and far between. So that's a core skill for a paramedic, I would argue, is moving CT scans back and forth. However, we also did a fair amount of pregnancy cases, high-risk obstetrics, I guess would be the proper term, and just complex cases that the local physician just didn't feel comfortable about, or the family could afford to transfer them down the hill to the bigger center. A very mixed bag, but the majority of it was neuro and high-risk obstetrics.
Were there any cases that were a bit shady, and as you're driving down the mountain, having cause for concern?
There's a preeclampsia that was very borderline, but thankfully the journey from Kibosho to KCMC is only about 20 minutes or 10 if Marco's driving. So the beautiful thing about those 70 series Land Cruisers is they're very stable and a well-built machine, so you can do 120 down a rural logging road relatively safely. So time is on your side.
Nice. Were you there during the wet season? Was it rainy?
It was arguably we made the ongoing joke that the weather was better in Africa than it was in back home in BC, and it was cooler in Africa than it was back home in BC. It was the climate was incredibly stable up on the hill there. It was typically anywhere between 16 to 22 degrees and overcast during the mornings, sunny during the afternoons, with the occasional light rain early in the morning that just burnt off. And there were a couple times where there was some good rain that came down. I think only once or twice over the 4 weeks that we were there. And it's interesting how they have to adjust their transport courses or routes down the mountain depending on the weather conditions. I remember talking to Patrick, one of the designated drivers for the ambulance, and he said, well, if it's dry, we can go this route and it's about 20 minutes. But if it's wet, we have to go the long way around and it takes about 30. So it's interesting how they adjust their course depending on the weather conditions for these roads.
Yeah, the long way around has more hardball, so it's better for during the rain.
Yeah.
So tell us about Kibosho. What were some of your experiences? Tell us about the ward. What was your favorite ward, the two of you, in Kibosho?
I think you probably best place to start would just be, what does a typical day look like in Kibosho start to finish? Because really, we would go anywhere and everywhere between all the wards. But what I found interesting was the schedule and the culture and the pattern of how they start their day. So typically we would get up around 7 o'clock in the morning. The sisters would prepare breakfast for us. There's local tea, there's coffee, and a couple of unique, I shouldn't say unique, but fresh fruits and avocados and stuff like that from around the parish. We go down 7:30. They start a prayer for the general staff. So all the staff members in the facility get to sit for about 20 minutes. And there's a prayer session in Swahili and a couple announcements. And then after we're done that, Cole and I would then drop down to the conference room in the bottom floor with the physician group, where they would go over any interesting cases. They would review cases and admissions and patient changes, conditions overnight via the on-call physician group. And then from there'd be kind of some more medical-driven conversations, practices, best practices, or changes to practices. There was a number of times where we had specialists from KCMC, pediatricians, come up and speak to, a very specific type of hemophilia found in pediatric populations, blood typing and testing and so on and so forth. New medications that they're stocking at the pharmacy. So just small little bits and pieces like that. And it was the two of us and anywhere between 4 to 6 physicians that would cover all the wards. And then after that, it would be they do enjoy what they refer to as break tea. So they would go and have a quick tea before they would come back to their designated wards. And so where Cole and I spent the bulk of our time was in the emergency ward with Dr. Mangana and Dr. Marco. And we would do rounds. There's approximately 4 emergency observation wards that they look after from an emerge setting. And there's the male ward, there's the female ward, there's the post-op ward that they would look after, as well as there's a small pediatric emerge ward that was on the bottom floor there that they would have pediatrics present to and standard observation if they were acutely sick. And rounds could take anywhere between, depending on the how many that were present, could take between 2 hours to sometimes upwards of 3-4 on a busy day. What we found is specifically after a weekend and on a Monday morning, there'd be a few more presentations than when we left on Friday. But as soon as the week kind of rolls around, come Thursday, Friday, a lot of them have either been discharged home or have had the opportunity to discharge up to some of the other medical wards on the site. And then after that, after the rounds are done, then typically we'd start seeing patients that were self-presenting to the emerge ward, kind of on a triaged acuity basis. So a lot of outpatient follow-up, a lot of new patient presentation, as well as, Cole and I made the joke, we got a little nervous every time we saw a pickup truck with a couple people in the back of it roll up to the entrance to the emerge, because that was an indication that there was something always interesting that was about to present to the emerge / recess room there. And so that would kind of take us through the rest of the day, and depending on what walked through the doors that day, we could be doing just minor assessments, treating asthma, treating there's a lot of diabetics that presented, a lot of advanced heart failure, and that was really cool, because from a Western civilization standpoint, we don't see a lot of that, because everything is very well managed and identified before these become problematic. And so to be able to see some of these disease pathologies in their advanced forms and unmanaged forms was really powerful, and added a lot to our practice and understanding, and being able to identify some of the processes, some of the things that go on in more of these advanced states, and how to turn these people around. And yes, it does take a little bit of time, but to be able to have the understanding of what to look for, and some of the the small things that you can do right off the hop really make a big difference. So to see some of those present was very interesting, as well as we did a number of what they refer to as minor surgeries that by standards back in Canada, back in the UK, back in the United States, might have undergone general anesthesia or been referred to by a surgeon. But that was a very interesting experience in of itself, and I think that there's a lot of big takeaways as to how you can manage operative patients in those environments. So that I took a lot away from those from that standpoint.
Yeah, it's to touch on the minor surgery thing. You can see me doing air quotes on the other side of the world. Of course, it's an interesting experience the first time when you see surgery being done without general anesthesia or even procedural sedation. And then, of course, that leads to a discussion afterwards. And the way it was put to us, and it makes sense retrospectively, that they go to medical school, they're trained in the way that all the British doctors are. They have the exact same knowledge as the doctor would in the UK doing the procedure, but they go, well, this is Africa. I don't have the ketamine to do it. But it needs to get done, so we say sorry and we do what needs to be done. So they make it work with what they have, and it's just an interesting, like as a Westerner coming into that for the first time, that's eye-opening for sure. But when you break it down of how we've ended up where we've ended up, it makes sense, and can't fault them for it.
To kind of build off of what Cole was saying there, our practice in BC and Canada here, I will normally do a number of procedural sedations and inductions via ketamine, via midazolam, a number of times during my rotations here on the streets in Vancouver. And so for me, I'm very comfortable, and I lean heavy on my ketamine and my midazolam, and even fentanyl to that matter, if we're doing kind of a multimodal approach. And even to do IO placements, even to do minor invasive procedures, chest decompressions and stuff like that, where feasible, we'll do a procedural sedation of ketamine. But to see how they were doing some of these more invasive procedures in Africa and using just lidocaine, and that was really, really interesting. And the amount of work that they can do, and the amount the effectiveness of lignocaine or lidocaine, depending on the brand and what you call it, the amount of the scope that they can use and what they can do and the procedures they can conduct with just using local anesthetic was hugely eye-opening to me. And actually, I wound up writing the bulk of my thesis while I was in Africa at Kibosho there for the program on the use of pre-hospital local anesthetics and nerve blocks. And to see some of this more invasive work in live time, and having an ongoing appreciation and dialogue with the physicians as to why they're doing it, where they're doing it, really helped lend a lot of context, not only to my medical knowledge and practice, but also to my thesis. And it was really, really eye-opening to see the scope of work that they can do with just using 10 to 40 of lignocaine locally. And so that was a really cool process. And to understand that they reserve their ketamine for their surgical procedures. I think I saw ketamine facilitated sedation in the emergency ward once in our 3.5 weeks that we're there. And that was from what I recall, a bit of an odd case. And because more often than not, they only have a certain amount of ketamine and it stays in the operative theater.
Yeah, I definitely underestimated the power of 2% lidocaine. I mean, it's in our toolbox for suturing and all that, which it's good for, but I've definitely underestimated having a 50 mil vial of lidocaine in a remote area, because just do your max dose that no one does to make sure that it's a safe amount, and it's impressive what you can facilitate just with a hefty dose of lidocaine.
That's excellent learning. And what type of procedures were they doing with the lidocaine?
A lot of suprapubic catheters. That was the flavor of the first week there. A lot of various syntheses of various varieties, pleural, abdominal, mixed bag, really. And they had a lot of infected C-sections, which presented and had to get very aggressively debrided. It's interesting, in Tanzania, having a baby is free, presumably because it's a Catholic hospital. However, any of the follow-up care is not. So you end up with a C-section, and okay, cool, your baby's born, congratulations. But the $2 to $3 of antibiotics are not included, and a lot of people can't afford that because their system is very pay-to-play, even more so than the U.S. So they end up infected, and it gets pretty aggressive pretty quickly. So there was 3 or 4 ladies at any given week that would have to come in every day and get this incision opened up and debrided and everything. At the same time, there's lots of various trauma. There was a human bite on a dude's hand that he ended up losing his finger. Various burns and gangrenous feet. So a lot of surgical debridement they facilitated with the lidocaine.
This is a really good opportunity to jump in and kind of just highlight some of the social determinants of healthcare that I had never witnessed before in a healthcare system. And I can now understand and have a greater appreciation for some of the diagnostic skills and assessments you have to have as a clinician, not necessarily tools at your disposal, but as a clinician, given the challenges of the healthcare system that they have down there. And it's a very interesting system. And like Cole alluded to, it is a user pay system. But where it differs from a user pay system from the program in the United States versus Tanzania is that, for instance, if you have someone that presents to the emerge, they're feeling unwell, general malaise, and a little bit of chest discomfort, that individual would have to have their family go and pay prior to for the ECG, for the lab work, before they can even conduct those tests. And so the difference in some of these other systems is that the test would be done and you'd be given a bill later. And so this system in Tanzania really leans on the clinician's ability to conduct hands-on assessments, to do the tactile firmness, to do some of these more these skills that aren't necessarily emphasized in Western medicine, because we have the advent of point-of-care ultrasound, because we have epochs, because we have all of these point-of-care assessment devices that we lean so heavily on to give us solid numbers back, rather than really exercising and leaning on our clinical gestalt. Because unfortunately, these individuals cannot afford the 5,000 shillings for the blood work or the 7,500 shillings for the ECG. And so that's where I really learned to appreciate some of the subtle nuances that the physicians have and that they do to really help narrow down and understand their what they're dealing with. And so a fantastic example of this is patients that we saw a lot of unmanaged heart failure or exacerbation of heart failure. And one of the things that I was surprised about that is a zero cost to the patient is the application of Trendelenburging these heart failure patients to help in kind of offloading some of the fluid. And yes, it's not an immediate thing. It takes 24, 48 hours to have effect. It is of no cost to the patient. And to see, we Trendelenburged a number of these patients with a very good degree of success. And it's like I was trying to highlight, is the no cost to the patient versus the cost of the medications for the furosemide and so on and so forth. And that was the interesting challenge working within this system that we kind of had to adapt to as Western medical practitioners, is that it costs the patient nothing for me to sit there, to percuss, to do tactile firmness, to listen to the chest, to listen to heart sounds, to all of that stuff. It costs nothing to the patient, whereas the ultrasound is going to cost 4,000 shillings that they may or may not have, or that they need to save those shillings for the medications. And prior to, what I found really unique was, prior to any of these procedures taking place, the family or the patient has to go to the payment desk to pay, to have the receipt, to bring the receipt back, to show the doctor, and then the procedure can take place. Or if it's medical equipment or medications, they would come back with a cardboard box of normal saline, of IV tubing, of IV starts, of whatever medication it was going to be. And so that was an eye-opening experience, and understanding some of the impacts of the social determinants of access to healthcare in different parts of the world. So I really appreciated the nuances with that, and some of the reinforcement of these really basic and rudimentary assessments and procedures that we can do that are no cost to the patient, and something that I definitely am looking for opportunities to roll into my practice back here in Canada.
Well, and further to that, and I remember we had a conversation one day during rounds, in North America, what's it to hit another ECG on the machine? In our practice, sometimes you do 10 or 12 of them until you get the one that you want. And does that really change anything at the end of the day? Where in this system, you might get one and you're not going to be able to read 2 of the leads to your satisfaction, and that's it. And the same, in the ICU world, you get labs done every morning. And is that really necessarily going to change the treatment? Yeah, sometimes it will. But in this environment, if you're even going to get the labs, you're only going to get it once. So it sometimes is a challenge to see if what you've done works. So then, like Greydon is saying, you have to fall back onto your gestalt and those basic clinical skills that a lot of people no longer rely on with the availability of point-of-care ultrasound and CT scans for everybody. So it really makes you wonder, do I need to do this, and actually will it change anything for the patient and their management?
Well, and that's the interesting difference too, with the user pay system there. I having worked in ICUs and been a student in a number of different facilities, both in Canada and the United States, we're very much here in the Western culture proponents of, in street medic terms, the kitchen sink approach, where we throw everything we have at the patient and see what sticks and what works best. And we are very aggressive with some of our interventions because of the resource availability that we have. And to see the inverse of that on the side of the mountain in Tanzania and Kilimanjaro, where it's more of a ramp-up approach. We're going to see where this goes. We're going to see how this develops, and then target specific portions of this so that we're not draining all of our medication, so that we're not utilizing or we're not costing the family more than it has to try to correct some of these diseases. And so to appreciate the differences between the two systems and have to change your mindset with, is what I'm doing for the patient is in their best interest? Is it going to have 100% efficacy? On a previous podcast with Mike Tricconi, he mentioned the trying to run a cardiac arrest in some of these facilities. Having run one recently on the streets in our system here, where we're using several amps of epi, and then we also have the advent of using calcium, of using bicarb, of using all of these different pharmacology supports or interventions through our cardiac arrest. Tricconi alluded to that. Sometimes it's not worth the $4 of bicarb in these arrests because there's no efficacy behind it. So why are we going to waste the family's shillings on something that probably doesn't have a good outcome? And so to apply that mindset to general medicine was really interesting, and really tailoring and ensuring that your treatments have the highest yield that they can, rather than just throwing it at the patient and hoping for the best. It was an interesting mindset change.
So what are some of the old school clinical skills that you used for the hands-on assessment, non-technical assessment that you were doing on these casualties?
I found myself in our practice, pre-hospital practice, sometimes it's not as feasible to be doing percussion, to be doing tactile fremitus. And I found myself doing a ton of that on the side of Kilimanjaro. There's a lot more. I also picked up a lot more little nuances of observations of visualizing the terminates in like nasal terminates in young children, to understand whether this is there's nasal septal defects, or there's congestion, or how are we going to best understand whether these kids that are obligate nose breathers that are now mouth breathing, what's the issue behind that, and is it worth it sending them to X-ray right away? Is it worth it for that cost when it costs nothing for me to visualize with a pen light in my own eyes whether this is congestion or whether there is a defect or so on and so forth. A lot of auscultation, a lot of where we may not have, or it may not be cost effective to run an ECG. And don't get me wrong, in BC, I love my ECGs. I'll run probably upwards of at least 20 of them a day, depending on my patient profile. Auscultating, listening for those clicks, washes, those murmurs in those environments, to listen for any echoing, all that sort of stuff. And really getting good at it and honing those skills and being able to save the family the 5,000 shillings of the chest X-ray to just have a really good quality auscultation of the chest in multiple areas may have been more beneficial than just sending them to the chest X-ray. And so now they can afford the steroids, they can afford the Ventolin and so on and so forth like that.
And I think we take for granted in North America that everybody in the hospital is walking around with a cardiology level stethoscope, because that's what we've always had in our career, because, you got to buy the cool one when you're in school starting out. That's not true elsewhere in the world. And even these physicians don't even have their own stethoscope, for example, and they're sharing one in the entire unit. And nurses definitely don't have their own in that system. And you take for granted, like, okay, you've got a master cardiology from Littman that you just used to listen to lung sounds in the back of the ambulance. But when you're in that environment, in the situation that Greydon just described, you can actually use that tool for how it's designed, and it's actually impressive. And Greydon is fortunate enough to have one of those electronic stethoscopes that Echo makes, and it's pretty game-changing. And especially when you're teaching, which, you always are in some degree, it's a valuable tool to, again, maybe save that X-ray, or, well, you won't really save the CT, but you kind of take for granted what you have access to.
And what was even more interesting is how new age technology is slowly integrating into some of these remote and rural practices, even in some of these areas overseas, and how the feasibility of utilizing like the echo stethoscope that's got the recordable function on it. I don't use that every day in my practice. I used it more in my practice in Kibosho than I do on the streets here. And I can see how the advent of sending some of these lung sounds, some of these heart sounds via my cell phone to a specialist 30 minutes down the road at KCMC or the regional facility can hugely impact a patient's care. Meanwhile, here in the system that we work in, the system doesn't necessarily allow for that. And so same thing with the butterfly IQs, being able to take pictures and the ultrasound findings and send those to someone 30 minutes down the road or 3,000 kilometers away to have a clinical consult on the side of the mountain, say, this anechoic space we're seeing here, I'm not too concerned about it, can be hugely impactful in some of these remote and rural areas. And I think that that's the focus of healthcare moving forward, and to try to allow for a broader access to high quality healthcare is going to be the impacts of telehealth and remote health assessments, and being able to send imaging and audio findings to these specialists in more established facilities. And so I think that that's going to be a really interesting way that we're going to see healthcare being shaped in the future. And I'm quite excited to see where that goes with the advent of the butterfly IQ, with the advent of the Echo electronic stethoscopes, and who knows what else is going to come out of the woodwork here as technology evolves.
Would you have wanted more old school clinical tests and skills taught on your Masters of Austere Critical Care?
We're fortunate enough to have an established practice and a practice that is well adapted for Western medicine. What I think would be a great benefit prior to going to specifically a place like Kibosho would be, like you said there, Abrick, some of the more old school clinical assessments. And, you look at the FP-C, look at the CCP-C, we talk about all these different signs, and I think they're underappreciated in Western medicine, because, well, why am I going to go through and do these different signs when I can just take my point of care ultrasound device, ultrasound in there, and gives me 90% confidence in what my provisional is, when I don't have that on the side of Kibosho. And understanding the why and understanding the context, and having a faculty member saying, you're not going to have this, so you're going to need to know this, and getting a refresher on some of these, like these old school skills you see in the books of, Nancy, one of the textbooks we use here in Canada, like the old Nancy Carlin's edition from 1995 is still alive and well and very applicable to the practice in rural Tanzania. And I think that that's such a unique thing when you look at it from the context of medicine, how medicine has evolved, and how that book is still relevant in certain areas of the world because of the resources that are associated with that area.
Maybe not the mass pants, though. We can leave those out.
Well, that's the beauty of this, isn't it? That you can find some of these old schools practice in 1950s, 1960s medical textbooks, make sure they're evidence-based, and then bring them into Kibosho to practice. And in anything that's not evidence-based, you can bid.
And I think that's a great point there, Abrick, is contrasting the evidence-based skills that are still applicable and against new findings, against recent articles, against, up to date. Is a huge system that we lean on here, especially in Western civilization, and being able to contrast some of the results and findings with your old school assessments against what some of the newer findings are is really helps maintain relevancy in that practice.
So that's bringing experiences into Kibosho. Let's flip that around. What experiences did you have in Kibosho that you can now bring back to your clinical practice in Canada?
I think one thing that we both realized within a day or two for sure, is that people are very resilient at the end of the day. And I think they're more resilient than we give them credit. And maybe it's the paramedic, hit problem with hammer kind of mindset that our education raised us as. But, this lady's been in heart failure for 3 weeks. Another 3 hours is probably not going to have a suboptimal outcome, where in our system, it's like, go, 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 do not even stop and collect the $200. Like, you need to fix this now. And there is the time and the place for that, for sure. But at the same time, if you're like, yeah, no, you need some Lasix and you need some non-invasive, you need a bunch of things, it might take 6 hours for the family to, facilitate that. Or maybe the family member has to go drive down to KCMC and get the pharmacy to mix up some 3% saline just for you. So that they might wait the entire day shift to get any sort of intervention. And these patients are still alive at the end of the day, which took us by surprise, to be honest. And, there's a time and the place for, airway, breathing, circulation, drive fast. But at the same time, like, take a step back and actually figure out what's wrong with this patient, because she'll sit there in her flash pulmonary edema for 4 hours if you really have to. I mean, that's ethically in North America not appropriate, and don't condone that if you have the choice. But at the same time, like, people are pretty, they'll pull through. And we essentially saw this in our pediatric population with our, we've got kids coming into Kibosho that are in like full-on type 1 and or type 2 failure that probably would have been anesthetized in our practice. And, you just give them some IM steroids and maybe a single dose of Ventolin and come back in 4 hours and hope for the best. And it works, which, I mean, it's anecdotal evidence, of course, but it's just very interesting to see how just give them some time.
It was really interesting. I worked yesterday. I was having a conversation with my colleague who was asking me about my experiences, and we laughed. We would see on a ongoing basis patients presenting to the emerge in Kibosho with saturations in the low to mid 80s, and in our system here and across North America, anything less than 94, you need to start intervening. You need to start applying oxygen. Having taught a number of paramedic levels here in Canada, our very initial level of paramedic, of pre-hospital care provider, is taught, you see anything less than 94, you're giving oxygen. You're giving high flow oxygen in high concentrations, 15 liters a minute with a 95% FiO2. And in Kibosho, these patients present in the mid 80s all the time, and they're fine. And because they only have 4 oxygen concentrators on the emerge ward, you may not get oxygen because of the resource availability, and they are just fine with that. And my colleague and I, we laughed about it because as paramedics, we have an inherent need to fix the number. Well, let's correlate that number back to the patient presentation. Because they're 95%, or 85% now, and they've been tolerating 85% for who knows how long, a number of days to weeks, they're going to be okay for the next several hours, pending that they're not in any sort of respiratory failure. And so just to correct a number for the sake of correcting a number, we talk about bringing practices back to Canada, I'm much more tolerant of my decreased oxygen saturations now because of my experience in Kibosho. And I don't feel like I need to fix the number right away. Let's investigate. Let's get a few questions as to why they're presenting with this saturations of 87. My threshold has changed ever so slightly, and my comfort has increased a little bit with that. And so those are the lessons I've taken back from Kibosho, as well as we don't necessarily need to hit hard, hit heavy right away. We have a little bit of time to gather some more critical information to really make a determination of what the goals of care and how we're going to care for this patient, the interventions that we're going to do along the way, in order to really ensure that they're getting the best care. And so what I mean by that is we're a very intubation heavy system here in Western Canada. And to take the 2 seconds to understand, if I intubate this patient, I'm going to be tying up an ICU bed. I'm going to be tying up an RT. I'm going to be tying up a ventilator if I intubate in the field. Am I intubating for the right reasons? And my experiences in Kibosho, because I wasn't able to intubate, really helped lend a little bit more context and information, and change my threshold ever so slightly to, well, let's wait a second here. Let's get some more information and have an understanding that my actions, my interventions of tying this airway up is going to have long-held implications. And there's lots of data out there to support if we don't intubate people, they tend to have a shorter duration and stay in a hospital, right? And obviously, I'm not advocating not intubating people, and we just really need to be intubating the right populations of people. And so that was a cool practice and experience that I've taken back with me because I've been handcuffed in Kibosho to not having definitive airway interventions.
But that being said, it's a good segue. We had, pneumosepsis, 50 shades of pneumosepsis at any given time. We had the opportunity, well, more specifically, my colleague had the opportunity to essentially bring ARDSNet to the side of the mountain. We were doing our rounds one morning, and, I think we joked to the doctor that this patient needed to be tubed, and that he made fun of us, and we went about the conversation. And we said, well, what about non-invasive and CPAP? And I guess we'd never talked about that up until that point in time. And they're like, oh, well, we have a CPAP machine in the filing cabinet. Yeah, does that work? And it turns out one of the other paramedics, Simon, left a CPAP machine behind, some fancy German contraption. And we ended up deploying it on this patient and gave it 12 hours, and it worked. And it became like the talk of the hospital to be like, look at what these Canadian boys did. This patient was like this, and now they're like this. Maybe we need to start incorporating this into our practice.
Yeah, to kind of add a little bit more context to that patient, that was a very interesting patient, and actually one that I wrote my case study on for 708. And essentially, this patient presented with bacterial pneumonia and shortness of breath over the last several days. And I believe on day 2 or 3 of his admission to the emerge and was under observation, had a thrombolytic event and had what was presumed to be at the time a stroke. And the complication that arose for that was we believe he aspirated. And they wound up doing a secondary chest X-ray, and it seemed like something right out of an FP-C or CCP-C review course. Well, what do you see in this chest X-ray? Well, I see ground glass particulate all over. Which you kind of accompany that with the history of the presentation, and then you start getting into the Berlin measurement for ARDS, and we talk about the lack of point of care testing. Well, the calculator for or the methods that are used to confirm ARDS is obviously your PF ratio. Well, we don't have access to that, and so to understand that we've got a chest X-ray aligning with the detrimental findings or aligning with the findings consistent of ARDS, that we have possible edema that is non-cardiac in origin, and that is requiring supplemental O2 to maintain adequate saturations. Well, I could say with a high index of suspicion that this patient probably has mild symptoms of ARDS. And so we had a really good discussion, because Cole and I looked at each other. We had a great conversation with Dr. McGann. We're like, you know what, in Western Canada, and actually in Western medicine, this patient would be intubated from a stance of airway protection and to just give the lungs a little bit of a break here. And so we talked about, you want to get positive pressure into these lungs and keep the expansion, keep everything splinted. And that's when Cole said, well, we have the CPAP device. And we roundtabled it between Dr. McGann and Cole and myself. Okay, let's try this. And you talk about one of the highlights of this. You talk about resource-limited ICU. And I think back of our time in Malta there, ABRIC, where we were doing the eye care course. And we had all of the monitoring devices lined up and put on. And you had to use 5 different monitoring devices placed in various areas. Compared to our one-hit wonder, the LifePak 15 that we have here in our normal practice, and having to saran wrap it to a SAM splint to there's my LifePak 15 with my thermometer, with my 4-lead ECG, with my SpO2. And so we took it, funny enough, we took some of the learnings that we had in the eye care program and applied it to this patient. So what we wound up doing is we wound up putting the nasal cannula on this patient with the oxygen concentrator to give us the FiO2 side of the ARDSNet protocol, and then proceeding to apply PEEP in a staged approach. And because the oxygen concentrator only goes up to 6 liters, because it's a low flow, we have to opt for a low FiO2, high PEEP strategy in this patient versus the inverse of it. And so we were able to, and fortunately the device that Simon had left for us actually had a ton of metrics that were available on it, such as flow leak, tidal volume, rate, all that. And what was interesting was having to correlate some of the German metrics to metric we practice with in Canada, so like centimeters of H2, and I forget what the German metric is for essentially positive end expiratory pressure. And so we wound up placing this mask on this patient, dialing the PEEP in, starting at 5, escalating to 7.5, escalating to 10, escalating to 12.5 in a staged approach, and letting that sit for an extended period of time, and then coming back and reevaluating. And so as we were upping the PEEP on this patient, obviously one of the things we want to look for is any precipitous drops in blood pressure, any drop in heart rate, to give us an indication that this individual is getting some relief from the respiratory distress. And I will never forget this image in my head of having an NIBP cuff attached to one arm of the patient, having the second NIBP cuff attached to the other arm of the patient, in order to corroborate the blood pressure to ensure that we're not precipitating any potential hypotension. And then on top of that, having 2 finger pulse oximeters to corroborate that we are getting quality and realistic metrics on this patient from a heart rate and from a pulse ox standpoint, from a oxygen saturation standpoint. And to me, I looked at that and I said, this is rural, remote, resource-limited ICU work in the rough. Like, we see a ton of ARDS patients in ICUs and critical care units across the country, especially when we start getting into, I had the opportunity to be in some of the ICUs during COVID, and having to manage ARDS patients in those settings. And to see that we were doing this on the side of the mountain, 4,500 feet up, the side of Kilimanjaro in rural Tanzania, with finger pulse oxes and NIBP cuffs, a nasal cannula, a oxygen concentrator, and a CPAP device, I thought was probably one of the coolest things, and really is the essence of what this program is all about, this austere critical care. And to me, that was one of the highlights. And it was interesting because we let that sit for, I believe, upwards of 24 hours. And we ended up being able to turn the patient around. And by, 3 days after the intervention had started, this patient was talking, had good pallor, and was able to be discharged with the support of physio going home. And meanwhile, had we let that start of that ARDS process and that bacterial pneumonia really start to fester for an extended period of time, I feel it would have been a different outcome. And those sentiments were shared across the physician group at Kibosho. And it was funny, they, like Cole said, there was a little bit of the talk of the town that the Canadian boys had pulled out this German CPAP device and had decided to ARTSNet this patient in the emerge ward, because the CPAP device had not necessarily come out after Simon had dropped it off. So that was probably one of the coolest experiences I've had in Kibosho there.
And further to that, one of the awesome things about Kibosho, and I'm sure KCMC is the same thing, but I can't attest to that, is there's really that sense of one team there. And obviously we were there to learn, but they were also there to learn from us. And it was a two-way information highway where we were able to impart some of the evidence-based ICU level critical care stuff coming from the West. And at the same time, they were feeding us the primary care and surgical care stuff that we would learn if we went to medical school. And it was just a beautiful symphony of, here, I'm teaching you this at the same time you're teaching me this, and everybody's learning and everybody's benefiting from it.
Yeah, it's like too much to build on Cole's point there. One of the practices we have here in Western Canada is we see a lot of electrocardiograms, a ton of electrocardiograms, and that's where I have no qualms about printing off 6 12 leads on a patient that I'm taking to the hospital and looking for evolving changes, and appreciating the subtleties of some of the wave morphology in these 12 leads. And as soon as we got the opportunity to have a look and remark upon a few 12 leads with the physicians, we actually wound up engaging and doing a lot of collaborative teaching with the physicians there, in regards to, they would present a certain ECG to us. They said, well, I don't think that this is an ongoing cardiac ischemia issue, but there's definitely either old damage here or this is a demand problem because they're hypoxic. And it was really cool to be able to share some of that, and for them to come back and share, how will we manage a CHF patient in a resource-limited environment? Let's Trendelenburg them. Don't believe me? Let's come back in 12 hours and have a look. Hey, look at this reduction in pitting edema in the extremities. And I thought that was one of the coolest things ever was the, like Cole said, that symphony of sharing information and that blend of different approaches.
That's fantastic. And I've been to so many hospitals throughout sub-Saharan Africa, and Kibosho and KCMC as well, but Kibosho has been just this beacon of a place to learn. So your docs there are evidence-based. They are getting their board certification, emergency medicine board certification, ICU docs, and they're hungry, aren't they? They're just trying to be better.
Oh, 100%. And a lot of the physician group is very young. I mean, not that I specifically know how old they are, but they're within a couple of years of Greydon and I, and they're not like 75 years old pre-retirement. They're young and they are fresh-ish out of medical school, and they're doing what they can with what they have.
And what was incredibly appreciated was the extension of respect that we had for each other. Even though we weren't physicians, Cole and I, we were treated with a high degree of appreciation and respect for our experiences as paramedics and the education and the information that we had. Whereas, there is in the medical system a little bit of a hierarchy where, between paramedics, between nurses, between physicians. But what really struck me was the collaboration, the approach of curiosity that these physicians had, and the extension of a professional respect. It was incredible and an experience like none other.
And the hospital seems to really appreciate the Quorum students. And I mean, I don't know how many you've sent there. I'm guessing maybe a baker's dozen. And they still talk about, they seem to have forgotten who you are. The pasty Irish white guy who's probably wearing shorts. But like they still talk about Simon. They talk about Mike, and he was only there for like 24 hours or something from what I recall. All those guys you've sent there, they are like, they remember them by name. They want them to come back. They enjoyed every student you've sent there. And I don't know if that's the same for every educational institution that partners with that university.
It's always good to hear the feedback from them. And I'll be down in October, so I'll be able to finally return. It's been a few years anyway, and it'll be great to meet these people again, and hopefully they'll remember me this time. So I have a question for you, lads. Since we are in the process of updating to the 3rd edition of the CoROM Field Guide, I wanted to ask, did you find the field guide helpful? Did it add or benefit your experience in Kibosho?
I mean, it made me scared of tropical diseases, so success there. In regards to the Kibosho placement, I didn't rely heavily on the handbook. That being said, in my clinical practice back in Canada in the remote areas, I definitely use it more in that setting. But it's definitely a handy tool to have, and everybody that I show the handbook wants one. That's my experience, at least.
I'll echo what Cole said there. Fortunately, we had the expertise physician group. We had the knowledgeable nursing group that was around us to ask questions and to help support us clinically. Where the field guide really shines is when I'm by myself and I need those prompts. I need those that information that I don't necessarily have on my cell phone, or I don't have data connectivity and stuff like that. That's where the field guide really shines. And the amount of information contained within that field guide, in its raw distilled sense, is hugely powerful to the remote and rural clinician. And where I can see that field guide really being a benefit is I have a 3-hour transfer in northern BC that I'm taking from point A to point B, and I need to start kind of cleaning up some of my assessments. I need to start dialing things in, or I need to refer to a checklist and stuff like that. And I don't have cellular service. I could pull up my field guide and flip through it, and away I go. We did carry it with us everywhere we went in Kibosho, and we looked for opportunities to use it. But because of the clinical expertise that surrounded us, and the presentation of some of the patients, really didn't lend itself to a good quality opportunity to pull it out and leaf through it. However, we did find ourselves in the afternoons and the evenings there, kind of perusing through it, having a look and corroborating the remarks and presentations of some of the patients we did see against some of the stuff in the field guide. So as far as the setting, I think using the field guide in a hospital-based setting, it doesn't provide for the opportunity to use it as it was intended. I think where it was intended is, and where it really shines as a massive benefit, is that remote and rural clinician who doesn't have the clinical support.
Indeed, we did not have a district hospital in mind when we designed it, but I was just curious to see how it did apply to your work there. So, Greydon, we've heard you mention that your master's thesis is about the use of lidocaine instead of procedural sedation. Cole, what is your thesis topic?
I haven't fully committed to that yet because Greydon's a little farther along, but my research interest at this point in my career is how to bring about the paramedic practitioner in the Canadian system and some of the operational and feasibility stuff around that. It's the way of the future, in my opinion, and the UK and Australia have thankfully paved the road. So hopefully I can do some sort of contribution to that in the long term. And the rumors are amongst the streets of Canada that it's coming, and the Paramedic Association of Canada has put it in writing that that's a career trajectory in the next, well, they don't really give timelines. So if I can contribute to the greater body of knowledge and help push that forward. That'll be my legacy project, I think, in my career.
Nice. Do either of you have any final comments?
My final comment, Hebrick, is going to be, if you have the opportunity to be able to do a remote and rural placement, to be able to do a clinical placement like this, my advice to those in the master's program, regardless whether you're a paramedic, a physician, a nurse, take it. The lessons learned, the perspectives, and the appreciation that you will have for a different system, a different practice, really helps lend yourself to appreciating the global scope of the nuances of healthcare throughout the world. It has made me incredibly appreciative of what we have here. It's also made me look for opportunities to say, hey, these are things that we can change, or this is what I experienced here. And if we had this back home, our jobs would be easier. Our quality of healthcare, our equity of healthcare would be a lot better. And I think as practitioners, especially in Western medicine, we can be very siloed into how we do things. And we get very one-track minded, and this is how it's done, and this is the only way to do it. And so to go somewhere remote, rural, to go somewhere that functions within a different system, a different framework, it will be an invaluable experience that you will carry with you throughout your career. So if you have that opportunity to go to Kibosho, to go to KCMC, or any number of the other placements that are offered within the master's program, I mean, I had such a great time that I would actively look for another experience like that, even outside of the master's program through Quorum, to go to South Africa, to go to other places that have clinical affiliations with Quorum, just for that experience alone. And that networking, that education, that experience that you will gain is something that you will take with you throughout the rest of your career and really help support and add context when you go to do research, when you go to evaluate your practice, when you do reflective practice. And I think it is something that you will be very grateful for that you've done in the long run.
Yeah, I think you hit the nail on the head on that one about medicine is most industries, I assume, are very siloed in their approach, and everybody likes to reinvent the wheel at great cost to the taxpayers. But the opportunity to see how other people do things, and you don't forget that experience. And even just with our friends, between our group, we've got someone who's worked in every province and territory in the country, and even the knowledge sharing that goes between that. So when you can extrapolate that or expand it to the worldwide level, I mean, even the people we met in our eye care, in our APIS course in Malta, those are professional connections for life now. And that's 14 or 15 countries from what I recall. And that's 14 or 15 ways of doing things. And you know what? If someone's got a problem down in South Africa, maybe, I know a guy who might be able to solve that for you, and vice versa. So it's just that open information exchange that kind of needs to come to medicine. Beyond that, okay, we all read the same research papers. Operationally, we should maybe look at doing that as well. So,
well, lads, you continue to impress me. It's great to have you again on our podcast. I imagine you're going to continue to do pretty amazing things, and we'll have to bring you back every now and again just to check in with you to see what you're up to.
Definitely love to take you up on that opportunity, Abrick. It's always great to be on the podcast.
Likewise, anywhere, anytime.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at quorum.edu.mt.